like to review a couple of housekeeping items before we begin. First, this is a watch and listen only webcast. There is a chat button where you can submit any questions that you may have, and we will get to as many questions as possible at the end of today's session during our Q&A. Following this webcast, we will be publishing the slides, the recording of the webinar, as well as a handout of all of the questions asked with the answers from our speaker. You will receive an email with a link to all the information in a few days. Now let's get started. Welcome to the Reimbursement Group webinar, From Acorn to Oak Tree, Rural Healthcare Reimbursement Opportunities. This webinar is a deep dive into the reimbursement opportunities available for rural health providers, as well as an overview of how to make the most out of them for your facility. Your webinar speaker today is Rural Healthcare Reimbursement Manager Karen Powalowski, who has over 25 years of rural health experience under her belt. Again, thank you all for being here, and now I'll hand it over to Karen.
Thanks, Lucy. Good morning, everybody. Thank you for taking time out of your busy schedule to be here with me today to speak on a topic very important to me, which is rural healthcare. As the title indicates, from Acorn to Oak Tree, there's a wide variety of sizes when you get into rural providers, the very small ones, maybe a single rural health clinic, all the way up to larger rural healthcare facilities and even those that are owned by systems. So I appreciate everyone's time together being here today. Just to give you a little background about myself, Lucy gave a nice introduction, but I've actually been in rural healthcare finance for over 28 years. The first 23 years, I actually worked in a couple different critical access hospitals in various roles, which gave me a great understanding and appreciation of what it takes to operate a hospital, regardless of the size, and more importantly, how fragile rural hospitals are and the importance of the community support. For the last 5 years, I've worked for the Reimbursement Group, supporting rural healthcare providers across the country to ensure that they are receiving the reimbursement that they are entitled to and are capitalizing on the different opportunities available to them. And over the past 5 years, I've also had the distinct opportunity to assist several rural hospitals as part of their finance team, including an advisory role as needed, oversight and assistance on a fairly regular basis, to actually being a full remote finance department with daily hospital interactions for a couple critical access hospitals. So I'm still heavily involved in the operations of the hospital side of it, but definitely focusing on the reimbursement again of what rural providers are entitled to. Of course, we always have a little disclaimer in here about the information that's being presented is current as of today. As anybody that's been in healthcare the last couple of years know, information does change regularly and not as much as it did for a while there with the COVID, but everything that is in here is current as of today and it can change over time. With the agenda and the objectives for today, we have a pretty wide audience today that's part of the webinar. So there's some that are participating from very small facilities to those that are actually with systems that own facilities, as well as individuals that are supporting partners of those rural providers. So I'm going to try to keep the information available for everyone to get information out of it, but also keep in mind that there's also some that are extremely experienced on the phone, or we call them seasoned, if you want to look at it that way, to those that have less than a year of experience in healthcare. So I'm hoping this will offer some to everybody that is on the call today. But the end goal for today is basically to share some background on the different rural healthcare providers, how they're the same, how they're different than their urban counterparts. Although the current pandemic has consumed a large part of our lives, both personally and professionally, over the last 27 months, my presentation is going to focus on what we consider more normal times, although there's a few instances that will divert. And then there's lots of resources available throughout the presentation and at the end. And as mentioned earlier, we're hoping to have time for questions at the end, although anybody that knows me knows I like to talk a lot, so I don't know if we'll end up with time for questions at the end, but I also know I do have a couple questions that have been already asked that are state specific that I'm working on following up on. So please feel free to put those questions in the chat. As we're going through this, keep in mind that there's also providers across the whole country on here. So I'm going to try to stay away from state specific information because, as we know, each state with their Medicaid program is different. So we'll focus more on the Medicare side. So the first question to start with, is rural healthcare really different? And of course, the answer is yes. Anybody that lives or works in a rural environment knows that it's different than when you go to the urban area. So even though you live or work in the rural area, it's kind of important to still know what rural is. And unfortunately, there's not one definition of it like you would think there is. It really depends on who's determining the information, who's determining the classification, what funding program is out there. So different rural classifications give you different opportunities, whether it's the funding, recruitment, retention, or reimbursement. And also rural areas are usually how the majority of is determined is that if it's not urban, it's rural. So there's really not like a rural definition. There's an urban definition. And if you don't fit within the urban definition, then it's considered rural. So rural areas usually look at the population, the housing, in a territory that's not included in an urban area. But keep in mind, depending on where you're physically located, one side of the street or the other can determine rural, what funding programs are available to you, when the data was last updated or reviewed, and then also how the data is interpreted. So all the different governmental programs out there, there's different definitions for different ones. So keep that in mind as well. So this is a phenomenal website out there. Someone has, if you have not used it before, it's called Am I Rural? The link is in here. It's through ruralhealthinformation.org. It'll give you your information specifically for you, what programs are available to you for the rural health clinic through different grant programs, other rural definitions. It'll indicate whether you're a health professional shortage area, or HPSA, as the good old healthcare acronym calls it, or a medically underserved area. It looks at the population. And I'll show you an example in a few minutes. When you go into here, it's address specific. So keep in mind to think about this and how this information is important to you. Look at your current scenario. Where do you currently own property? What are the current services you offer? Could you offer other services at other property that you own that you might not be? Or in the future, could it determine where you add new services, where you purchase property, where you expand clinics into rural health clinics? So when you go into this website and put in your specific address, you'll get 4 pages printed off on it. The first page is an excellent snapshot, and I just pick one random area. It is address specific. So keep in mind, whatever address you put in is exactly what it's going to give you. If you're across the street from that address, it could give you different results. If you're a mile away, it could give you different results. If you're across town, there's 70,000 different census tracts. So here's the census tract this specific location is. There's 70,000 different census tracts that will give you different information. It'll give you the location in the county. And of course, out of every disclosure out there, it also says that check with the program contacts directly to verify your eligibility. But this isn't a very good place to start when you're looking at different rural healthcare programs. The second page, and the other reason I picked this location is there is green and red. As you can see on the rural side, it'll be green, obviously good, you can move forward. Red, you're not eligible at that time. So when you're looking at this, the very first thing it'll tell you is if you're eligible for a rural health clinic, yes or no. And then there's also always additional links in there as well. It'll tell you if you're eligible for different federal office rural health policy grants. And again, everything goes back to if it's not in an urbanized area. The third page you get is a lot of other common rural definitions. And again, looking to see if it's not urbanized or area or urban cluster, it's considered rural. So think about different grant opportunities, both federal and private. Some of the information you have on here will also give you different scores that you can use for those private grants as well. The rural urban commuting area score is HRSA's own definition, which is right here. That's HRSA's definition that will help with different grants that are available as well through the Census Bureau and Office of Management and Budget. And again, the census doesn't define rural, it's everything that is not urban. And then the urbanized areas have different definitions as well that we won't get into heavy detail on today. The last page then gets into other shortage areas. So if you have a HPSA or health professional shortage area, the biggest thing to watch on here is when it was last updated, because it must be within the last 4 years if you're going to apply for a rural health clinic. And then your medically underserved areas are down here as well. But the health professional shortage area, again, will help with other reimbursement opportunities you have for your professional fees as well. So just keep in mind that this is a good place to look for a lot of different rural areas for different rural health clinic, especially if you're looking at starting a rural health clinic, but even getting into other grant programs or opportunities that are available to you. Also included as part of the Rural Health Information Hub, and I'm slightly biased, born and raised in Michigan, so I have the Michigan map up here, but every state that is out, all 50 states have this information out there. It's an excellent resource within RHI Hub. The data is available for every state, and it basically gives you rural health resources, including funding, local contacts for your state, recruitment opportunities as well. So it'll give you information on what different state and federal flex grants are out there, as well as recruitment retention opportunities as well. All of them were just updated in April of 2022 through HRSA and HHS data. And this is where we were talking before about the different rural what's rural and what's urban. So all these beige pockets that you see are considered urban areas. So anything outside of the beige pockets is considered rural. So in Michigan, for example, there's 420 different rural facilities. The blue represent critical access hospitals. The green represent rural health clinics. The red are FQHCs outside of urbanized areas. And the yellow are other rural hospitals, other rural PPS hospitals, not critical access hospitals. So if you go out to the website, there's information out there in every state. And again, there's other information out there as well. It's important to look at for other funding opportunities. So how are rural and urban the same? So people make choices as to where they want to live, but everyone still needs that basic healthcare services. They need preventative services, injury. They need healthcare services preventatively if they have an injury, if they have an illness, or for ongoing needs. One of the health disparities in the US today is the geographic location. Personally, I was born and raised on a farm in rural Michigan. I married a crop farmer, so my choice was more obvious to raise our girls in a rural area close to our families. For the majority of Americans, the rural setting might not support their culture or lifestyle choices, but regardless of a person's zip code or view from their front window, we all need access to healthcare services. So again, looking at the difference between the rural and urban, a majority of rural Americans lack access to stable, adequate bandwidth. And if we also look at other key demographics, poverty is higher in the rural area. There are more new jobs aren't in the rural areas. There's more disabilities, but rural areas are more entrepreneurial. But it's still very important and challenging job responsibility for each of you to provide those accessible healthcare to rural Americans. The couple stats that I found extremely interesting is urban areas make up 3% of the entire land country. So those urbanized pockets are only 3% of the entire land country, the entire land area of the United States. And almost 20% live in that 97% that's considered rural. So there's 97% of the country that make up 20% of the population, but that's a very big task for those rural healthcare providers to ensure that that healthcare stays accessible for those residents. So other areas that rural is different from urban, there's usually fewer options. It doesn't mean there's lower quality, but just because there's fewer clinical options, there is sometimes lower volumes. Transportation is also a major issue, although it's an issue with a lot of healthcare providers in the rural areas. The travel distances are longer, not necessarily the time it takes, but in the miles is an issue in rural communities. There's no public transportation, or Uber drivers don't exist in rural America. Plus there's more miles, and for those of us that live in the northern part of the United States, there's also that inclement changing weather that also can add more drive time. Recruitment side, it's also harder to recruit different providers. Again, this is another area we're going to talk about in a few minutes about other opportunities out there to help with the recruitment side. There's issues with recruiting for even clinical individuals, management, not just the C-suite, but department managers, clerical, even looking at the registration desk clerks, the, accountants, controllers, patient accounting managers. And this has been exacerbated even more through COVID with everybody, with all the different mass exoduses and resignations that are out there. When individuals can go to a fast food restaurant and make the same as your registration clerk or more, it makes it extremely difficult to start recruiting to this area. So this has always been more of a problem in the rural area, but it's become even larger more recently. Another area that for those that live in the rural areas are very familiar with is there's a significant local impact with having those rural healthcare providers there. Usually they're the largest employer in the area, and that they make a significant contribution to the local economy, but also in return. So if there's a factory in town or a large industry that all of a sudden closes its doors and leaves those rural communities, it can significantly hurt that rural healthcare provider as well. The community support is also important for the success of rural facilities, whether it be through millage, fundraising, utilizing their services, and retention of the staff. And usually the broad range of services, usually also in the rural facilities, they have to provide that continuum of care from primary care all the way through to long-term care. And they're also expected to look at other services needed to be offered in the community: home health, health fairs, long-term care, ambulance. When you're in an urban setting, a lot of times there's a lot of other types of providers, facilities, or organizations that provide those other range of services. There's also limited staff with the same reporting responsibilities. And I'm hoping anybody out there that works in a rural facility really understands that significantly, that there's still the same reporting responsibilities, but usually there's a lot less staff. And they actually have more responsibilities. They're more hands-on, and they wear a lot of hats when you're looking at the smaller facilities and the staffing model that they have. So looking at the rural strategy, in May of 2018, CMS published their first ever rural health strategy. So the focus has been starting to focus to look at rural health and other things that can be done to help support them. So it was the development of a strategic plan to improve healthcare in rural America, to reduce provider burden, to make healthcare in rural America accessible, affordable, and accountable. Although the last couple of years have kind of slowed that down a little bit, it is exciting to know that it is hitting the governmental and the Washington limelight to make sure that that rural strategy and rural providers are recognized for what they're doing, and in turn compensating to keep that healthcare access to the rural residents. But when we're looking at this, if we're looking at the different payers, a lot of times you need higher reimbursement because you have smaller volumes. It's also difficult to exclude when you need the patient. So it's hard to not be participating with certain payers, even though their reimbursement is sometimes less. And the other thing to keep in mind as a rural provider is, at the end of the day, you can't be all things to all patients, but you can be great at what you do. Generally speaking, in the rural providers that I've worked with, their patient satisfaction levels are higher than their urban counterparts, and they also have a higher retention of staff and providers. Again, sometimes with COVID more recently, that has not always helped in that area, especially on the clinical side, but it is generally that way in the past. And hopefully we'll get back to that way sometime soon as well. But it's really important to know the differences. So most importantly, it's important to know what reimbursement opportunities are available to you on the rural side, how you should be reimbursed, and then how you are being reimbursed. So just because you're entitled to it, you still want to make sure that you actually are qualifying for it, and then making sure you're actually getting that reimbursement at the end of the day. But keep in mind throughout this whole presentation and everything else that you hear from others, that your facility and your community are unique to you. So what works for another hospital across the street, a few miles down the road, across the state, or across the country, it's always great to look at best practices and what you can do, but keep in mind that everything you do is still unique to you. There's not a one-size-fits-all examples of perfect ways to do everything. So looking at physician recruitment side of it, it's not just the recruitment of the physicians, but programs to attract physicians and providers to the rural area. There's loan repayment opportunities. Sometimes this is harder to get those physicians, and right now it's actually extended into other types of providers, both clinical and financial, managerial, non-clinical. It's been extremely hard to recruit all of those, but getting into keeping those physicians involved in the community. Sometimes it's hard because they have a large on-call commitment with the smaller facilities. Sometimes with those lower patient volumes, it's harder to recruit specialists. But again, in a few minutes, we'll talk about how we can look at doing that. The other thing is, though, even though sometimes those physicians might have a little lower pay in the rural areas, usually in the rural areas, though, they're going to be one of the highest paid in the community. So, and they can live a lot cheaper in the rural areas. So look at other ways that you can sell your area and your services in your community to the rural, to the physicians to come back to your area and practice in the rural setting. So one of the programs out there is the National Health Service Corps. If you haven't signed up for that or looked into it, it does take a little work to sign up at first, but once you get in there, it's a program administered by HRSA, and it's eligible for all the different primary care providers listed here on the screen. There were new applications open that just ended a little while ago, but now is the time to look at that. And keep in mind, there are some auto approvals available for certain providers, and there's significant benefits out there on this website. So even if you aren't able to sign up right now, or if you're not already part of the program, there's significant benefits to go out there and look at and see what they can do. The job search, they can help healthcare workers find jobs in high need communities. Through their loan repayment, they offer programs to repay part of the school loan debt. Through their scholarships that are available to help pay for education as well. And there's just different facilities and different opportunities available there. So if you're not already aware of this program, please take it as an opportunity to take a look at it and see what's out there. And if you're not signed up, take this as an opportunity to start working on getting signed up for next year, because it doesn't cost you anything at the end of the day, and it's a very nice opportunity out there to keep that job search and those loan repayments out there for you. And it's specific to rural again. Going through and looking at the rural health pain points, I'm going to touch on this real quickly because there's anybody that's working on the rural healthcare side. I don't think there's probably any surprises on the list here, but basically on the rural healthcare side, there's continued vulnerability of rural health. There was pre-COVID, and there's probably even more so now. Payer rates are increasing and they're not keeping pace with the cost. Usually you have lower volume, so it's harder to negotiate with the payers. But keep in mind, it's important to focus on that geographic coverage rather than the number of patients, and use that as your negotiation with your commercial payers, that you're covering this huge geographic location area to help with them for their clients as well. Pressures on costs continue. Real providers tend to already be more efficient to begin with lower volumes and revenues. So sometimes at the end of the day, there's little left to cut to be more efficient. And then sometimes, and I'll talk about this in a little bit, sometimes you can cut your expenses too much, and then that can cause unforeseen challenges. There's also a risk with the impact to volume, safety, and quality. There's been a shift of payments to patient responsibility now. So when we start looking at the shift of payments to patient responsibility, the higher bad debt is definitely out there right now. The patient is now the third largest payer due to the high deductible plan, so it's important to keep that in mind. Hospitals continue to have to be strategic, but at the same time, it's really hard, and sometimes hospitals are hesitant to do that because they can't afford to swing and miss. They don't have usually an excessive bottom line or excessive cash reserves that if they want to try something new and different, they got to be pretty sure it's going to work because they can't afford to do that otherwise. So it's really important to look to see where you can expand services, where to contract them out, but also be competitive. And remember, you can't be all things to all people, but be the best that you can. There's also the staffing of scarce resources is a challenge. There's smaller providers in a large system. Sometimes they are different, and sometimes they're not always treated that way. And keep in mind that there's not that one universal definition of rural, that different governmental programs have different definitions of rural. So the 5 different rural healthcare payment programs that we're looking at today are the Critical Access Hospital, the Rural Health Clinic, Soul Community Hospital, Medicare dependent hospitals, and rural referral centers. And what we're going to kind of look at is the different backgrounds of them, the requirements, characteristics. And again, keep it in mind that the intent here through all these different programs is to reduce the financial vulnerability and improve access to healthcare for that 20% of Americans that live in rural America. These rural hospitals have the same regulations and requirements as the urban facilities, but again, they'll lack that volume to be cost effective or sometimes to break even. And keep in mind, as we're also looking at these, is there's significant cash flow challenges that anybody that's working in the rural facility right now completely understands, that Medicare payments are extremely low right now. Anybody that received a COVID advanced and accelerated payment loan back in April of 2020, they're now up to 50% reduction in the Medicare payments. Sequestration started again 1% as of April 1st. On Friday, July 1st, we're up to 2% sequestration. So the cash flow coming in has been really hurting a lot of rural healthcare facilities. The COVID funds that were abundant over the last 2 years have been decreasing, but the costs are still higher, whether it's your agencies, your travelers, or just your lower volume. Your cost per visit is definitely, or cost per procedure, cost per stay is higher than it was pre-COVID. Patient volumes are not where they were pre-COVID. And unfortunately, for those facilities that were cash strapped prior to COVID, the COVID funds provided were a Band-Aid, a temporary Band-Aid that's now becoming very painful as it's getting pulled off and those COVID funds are going down. So the first area we're going to look at is critical access hospitals. So this is another type of information that's out there in the Rural Health Information Hub. So there's national information and there's state-specific information. So again, take a look at that when you get a chance to look at what other opportunities are available for you in your state. And hopefully you're already aware of all of them, but if you're not, take a look out there and see what else is available for you. There's this is just updated as of April. So there's 1,358 critical access hospitals in the United States right now. Fun fact, there's actually 5 states without a critical access hospital, and that's primarily right in this area here. Every state had to start with a rural health plan in order for it to be able to offer critical access hospitals as an opportunity for providers to apply for. So Connecticut, Delaware, Maryland, New Jersey, and Rhode Island, actually there are no critical access hospitals in these states because I'm sure of their geographic location, but also because they do not have a state agency that had started that program. So when we're looking at critical access hospitals, it was a program that actually was established in 1997. And for those of you that have been in healthcare for a long time, this is probably redundant information. I apologize. But for those that are new, it's good to have a little bit of a background. So the program was established in 1997 as part of the Balanced Budget Act in response to the large number of rural hospital closures. There are almost 400 rural hospitals that closed in the 1980s and early 1990s. So the purpose of the Critical Access Hospital Program was to keep essential services in rural communities through cost-based Medicare reimbursement. There are several different qualifications that you have to meet. So you have to have fewer than 25 acute care beds. You have to be located so many miles from another hospital. You have to have an average length of stay of less than 96 hours. You have to provide 24/7 emergency care services. But with the Critical Access Hospital, what we'll talk about in a few minutes, there's actually opportunities as to how you can provide those cares a little differently. And for those that have also been in healthcare for a little while that actually converted to a critical access hospital, which I had done, you are really a hospital. And when this kind of is a little inside joke from in the past, if you were one that converted, sometimes those hospitals around you, then at least from my experience, they were very good about promoting the fact that you're no longer a hospital. They are real hospitals. They have the same requirements, the same responsibilities, and they're very, very important. And there's a significant amount of them across the United States right now. And I know there's a significant amount of you on the phone today too. So looking at the different services critical access hospitals can provide, again, critical access hospitals across the country, they're the same because they have the same requirements, the same reimbursement model. They have the same recruitment and retention opportunities. They have the same types of providers, generally speaking, but they're also significantly different based on even though they have to meet in a rural location, there's significantly different types of rural locations. Some are more remote than others. Some are closer to an urban counterpart than others. They have different services that they offer. There's different relationships. There's different recruitment and retention, whether you have providers that have been there a long period of time versus those that have turned over significantly. And when you have providers that have been there for a long period of time and then they leave, that is a major change in your revenue and volume that you need to keep in track of, especially when those providers retire and they've been in the community for a long time. The other thing to keep in mind is there's different skill sets. So a lot of times you'll see in the critical access hospitals that you might have one manager that manages a couple of the different ancillary departments. On your different therapies or these other services, they could be contracted or they could be employed. It depends on what you can recruit to that area and how much of a need you have. And again, the critical access hospital's purpose is to provide that essential services to their community. A lot of times, as I mentioned earlier, it's hard to recruit those specialists into those rural areas. So sometimes they'll rent space or they'll be there a day or two a week or a day or two a month, depending on what it is. But the most important thing to remember is with the critical access hospital, you can provide any services that any other hospital can, as long as you stay under that average length of stay of 96 hours. And more importantly, that you meet the community need. There are some critical access hospitals that don't have an operating room. There are some that don't have OB, some do. Some have swing beds, some don't. So there's a lot of variety once you get into the different models out there. So the different rules and kind of advantages of being a critical access hospital. First is the cost-based reimbursement at 101%. Well, the first question is, well, why are these critical access hospitals struggling if you're getting a 1% margin on your Medicare reimbursement? So the one thing to keep in mind here is that cost-based reimbursement is 101% only looks at allowable costs. So it includes marketing, it excludes physician recruitment, it includes other community service needs that you need to be providing, such as health fairs or other services that are not allowable on the cost report. So those are excluded from that 101%. The other thing we just mentioned a few minutes ago is that 2% sequestration. So even in the best world, let's say 100% of your costs are allowable on the cost report, you still have the sequestration in place. So the very best reimbursement that you could possibly get would be 98.98% of your cost. Anybody that works in math knows that that's still not enough to make a bottom line. And if you look at the average critical access hospital, 40% Medicare roughly, that's at 98.98%. Let's say your Medicaid business is roughly another 20%. Best case scenario cost 98.98%, probably not, but just in best case scenario. So that still leaves 60% less than cost. So if you have your Medicare and Medicaid as 60% of your business, 60% of your business is getting you less than cost. That doesn't even take into consideration self-pay. So 40% of your business is where you need to make your profit fund from. So that's why it's important to look at other funding opportunities as well, and other revenue opportunities, and also looking at your other types of contracts out there. So we really need to look at reviewing the payer contracts for your commercial rates, your Medicare HMO contracts for your car rates, and other sources of revenue such as 340B. And although some of these advantages and things that I'm talking about are critical access hospital specific, some of them will fall through to any other rural PPS facility out there, any other rural provider out there as well, even if it's a PPS. Looking at your 340B, still look at your payer contracts. A lot of times those payer mixes are still the same. The second opportunity as a critical access hospital is swing bed services. And again, swing bed services for a critical access hospital will be reimbursed at cost, not the SNF PPS rate. And that's really important there as well. Keep in mind, again, usually the swing bed services have a high Medicare utilization. So that's going to pull overhead down to that Medicare line on the cost report. And what a swing bed service is basically a patient that's in a critical access hospital or transferred back from another hospital to utilize swing bed to be utilized as a swing bed patient. They basically are a skilled nursing facility type patient. They still meet the same 3-day rule. This is an area that some facilities did very well within COVID. They were able to work with their urban counterparts if they had patients there that needed to be transferred back to that hospital. And this is important all the time because it keeps those patients in your community and brings them back to your community. There is a separate certification and approval, and there is a separate provider number for those swing bed services too that has a Z in the middle. Number 3, there's also significant cost savings for 340B. And also more importantly, see what you can do for you. If you're not already utilizing contract pharmacy revenue, look at that as another opportunity in your community as well, because that's another way to supplement that income for other services. Number 4, you're excluded from the provider-based rule changes. 5, we're going to be talking about rural health clinic quite a bit later, but there is opportunity there for quote unquote full cost reimbursement. Some of it has changed more recently. 6, there's professional provider opportunities. There's option 2 billing where you can get 115% of Medicare fee schedule. There's the HIPSA add-on for another 10%. Again, that's not unique to critical access hospitals. There's A82 opportunities there as well for your physicians on your cost report. Number 7, there's more flexible staffing requirements. You can have non-physician providers in the clinics. You can have non-physician providers in the emergency room taking care of patients as well. So that's another flexibility you have there. And there's also additional capital funding resources and options available, whether it's through USDA, Flex grant programs, or another good opportunity, as well as the HRSA grants that we previously mentioned. So when we're looking at the critical access hospitals through the Medicare cost report, so what I'm mentioning here is specific, even though it says critical access hospitals on it, keep in mind it should also be utilized for PPS facilities at the same time. Because at the end of the day, it's important to keep in mind that that's going to help you not only on Medicare, but on Medicaid. Through the critical access hospitals or the Medicare cost report, more importantly, it's really important to remember that they're cost-based reimbursed. Don't leave any money on the table here. So make sure you have your charges accurate with your costs, and that has stat allocations as well, because this is going to impact your current year reimbursement as well as your future year interim payment rates. Think of the cost report. For those of you that are familiar with it, this is going to be extremely redundant. I apologize. But for those that have not prepared a cost report or kind of heard it around the hospital before but don't really know what it means, think of it as a tax return. And even if you're not directly involved with filing the cost report, it's still important to understand the key components of it, making sure that there's communication. Everything that you do impacts the cost report. Again, on the charges side, make sure the charge master is set up appropriately. On the cost side, making sure the AP, HR, payroll, everything like that is also included in that to make sure it's reported right on your general ledger, which then will be reported correctly on your cost report. Keeping those stat allocations up. And then looking at any departmental cost to charge ratios swings from one year to the next. Monitor high Medicare service lines, whether it's inpatient or OR, and then they'll have the biggest impact on your reimbursement. Your low Medicare service lines, make sure you're reimbursed more than your cost. At the end of the day, when we were talking about that 60% being Medicare and Medicaid, you really want to hope that other 40% is making up the difference. But if you have some low Medicare service lines, make sure that you're getting reimbursed more than your cost. If not, look to see if you should still be offering those services. Limit your non-allowable costs too. Be creative here. Look at non-provider based activities, advertising, bad debts, anything like that you can do to help limit those non-allowable costs. Again, look at your charges. For a critical access hospital specifically, the patient's going to pay 20% of the outpatient billed charges. So make sure charges are not so high that the majority or all of the outpatient services are paid by the patient. And I'll have an example on the next slide. And then it's really important to model the reimbursement impact of anything that you do, not only in considerations, but it's not the only consideration, but make sure it's included in the process. Anytime you're looking at strategic planning, your budget process, contracting with other payers, purchasing buildings and equipment, leasing arrangements, physician contracts, starting new services, ending services, any of your provider-based entities, make sure you're looking at running a model or an interim cost report because you do not want any surprises. And it's also important to run the interim cost report throughout the year. If you think about the charges, anytime there's a volume change, your charges are going to change. Look at the costs. How have they changed? Has your payer mix changed? So it's really important to keep track of that since this is the majority of your business model or majority of your reimbursement. The other thing to keep in mind is your bad debts. Make sure that they're wrote off and sent to collection agencies and then returned as worthless, what they say, quote unquote, worthless. Have everything available for your auditors. This has been a high area that the auditors have looked at when they're reviewing your cost report for Medicare. So just keep all your documentation there. Get all your work papers for your cost report. If you do it internally, great. Make sure there's multiple copies of it out there. If you have an external preparer preparing your cost report, get the information from them too, because all these different opportunities that I'm talking about can be done retrospectively, but it's really important to make sure we have work papers and information to do that. Ideally, you want to file the cost report and be done with it and everything's perfect, but it's always opportunities to look for retroactive reimbursement. And there's been a lot of staffing changes. There's been a lot of ownership changes of hospitals, and it's been really hard to get information based off of that. So everything you're doing here, make sure you're supporting and more importantly, keeping the documentation there. So this was kind of the example that I mentioned a few minutes ago that I was going to talk about. So if you look at your Medicare charges, and let's just say this is the Medicare charges, you can see the Medicare costs are exactly the same, the $5 million. So if you have outpatient Medicare charges of $10 million, the same $5 million of Medicare costs, 20% of that, again, is going to be billed to the patient. So this is going to self-pay. So there's $2 million going to self-pay. You're going to get $3 million from Medicare. Same Medicare costs, but if your charges are lower, you're now going to have 1.6 million going to the patient, 3.4 million coming from Medicare. And again, the same thing here. So this is looking at your cost to charge ratio and applying it based off that. Same services, same Medicare charges. Keep in mind your Medicare cash piece here will show up within 15 days with a clean claim. Your coinsurance piece here, if you get paid on it, will take you longer than 15 days. If you don't get paid on it, then it goes into a bad debt bucket. Then you might get 65% on it, but that might be 3 years later. So just keep this in mind. Don't look at this as this being, okay, we could just drop our charges to get additional Medicare revenue and not worry about the patient, because there's still considerations to look at with commercial business as well. So it's another example. You need to model it and look at it. But from a price transparency side, it's kind of nice to know that if you can keep your outpatient charges same and not go up every year, this cost to charge ratio will go higher, which will allow you to get more Medicare reimbursement. Again, a very simple model. Every place needs to look at it specifically, because if you do have commercial payer contracts that are tied to charges, it's not something you're going to want to look at probably doing, or at least look to see what the impact of that's going to be. The other thing that's important is if you ever look at doing anything different with your charges, whether dropping them or doing anything different with them whatsoever, make sure you communicate with to Medicare and get your interim rate adjusted. Because if you moved from here to here, but you didn't let them know you're making a change, you're now going to be waiting longer to get that additional reimbursement. So you don't want to get hit in the short run with cash flow issues by making a change. But again, this is another specific site, specific information to look at. Looking at rural health clinics, this is the fastest growing rural healthcare type, and our second area we're going to look at today. There's actually been an additional, as of April, there's 5,092 rural health clinics. The program started back in the early 90s with 300 rural health clinics across the US, where there's now over 5,000 rural health clinics in 45 states. Again, the fastest growing rural health clinic provider type, it increased almost 1,000 providers over the last 5 years, or a 25% increase, and it continues to be moving in that same direction. So with the rural health clinics, again, you must be physically located in a HRSA designated health professional shortage area. Again, that same thing that I showed you earlier, myrural.org, go and take a look at that and then I'll tell you. But you must employ at least one non-physician provider, a nurse practitioner or PA that works at least 50% of the time when the clinic is open. And then there's different types of rural health clinics. There's the freestanding one, about 43% of rural health clinics are freestanding. They do have a reimbursement limit or per cap visit. They significantly got an increase last year. And then there's the provider-based facility ones. With here, there is provider productivity floor. There's FTEs and visits unless you get an exemption. About 57% of them are under the provider-based facility type. And it used to be there was no reimbursement limit, but now there is new ones as of 2021 as well. Looking at, again, the Medicare. So this was a significant change that started last year. So as of April 1st, 2021, any new rural health clinic, so if they were not grandfathered in or were not part of a rural health clinic or part of a hospital that had less than 50 beds, they now are at this limit of $113 per visit. So any new rural health clinic, whether it's rural health clinic that is freestanding or provider-based, they are now all at this $113 a visit. For those independent clinics, this was a huge increase for them. For the provider-based clinics, they are still under a clinic-specific all-inclusive rate cap, but it's based on their rate in 2020. But again, this is a very simple slide. Looking at that, there's a huge grid out there you can look at for more specifics. But keep in mind with these provider-based rural health clinics, there's a huge range here. There are some rural health clinics that are provider-based that have an all-inclusive rate of less than $100 a visit to some that are over $400 a visit. Volume and expenses when you're doing those cost reports are still extremely important. It's because even though there is a cap, if your calculated rate per visit is less than that cap, you will receive less. So if you think about the AR all-inclusive rate being capped and receiving less than that, if your expenses go down, if you have an increase in your FTEs, or if you have an increase in the visits. So again, the cost report is still going to matter here because we don't know how it's going to affect the rates in the future. Looking at the Medicare Rural Health Clinic, it's really important to have accurate visits, accurate FTEs, and costs are all extremely important. If you keep in mind, again, that cost report for optimal reimbursement is looking at costs, FTE visits, and a lot of other information. So cost for rural health clinics on a high level, you have providers, you have support staff, supplies, utilities, leases, rural health clinic management, accreditation expenses if you're accredited. Make sure you track the telehealth separately though, because that is not part of the AIR. And keep in mind to include all costs, direct plus step down, plus the stats if you're a provider-based rural health clinic. The provider FTE is another area that we find a lot of inaccuracies with. Keep in mind this needs to be by provider type, whether they're employed or not employed. So one full-time provider on payroll doesn't equal one FTE for rural health clinic cost reporting purposes. So when you're looking at this provider FTE, keep in mind if you have one FTE of a provider that's a 1.0 on payroll, but for example, they work 40 hours a week and they have 4 weeks of vacation or holidays or downtime, they're working 48 out of 52 weeks a year at 40 hours a week, they're really a 0.92 FTE, not a 1.0. So keep in mind that this FTE needs to be based on hours available in the rural health clinic to see and treat patients. It does not include CME, does not include PTO, does not include non-productive time, meetings, FMLA, anything like that. It is only looking at when they're actually available in the clinic to see and treat patients. On this one especially, make sure you document this very well. It's important to keep track of all that time and keep it. Looking on the visit side, make sure you're correctly reporting the visits. I know each of these are make sure you do this, make sure you do this, and it sounds really easy to do, but these are different areas that we've seen opportunities in the past. Reporting these visits, making sure that, keep in mind that there are stats you sometimes use internally for reporting your visits for purposes that don't equate to the same thing as a cost report rural health clinic visit. So usually internally, you want when you're looking at operational side, you want your total clinic stats to include every appointment, every visit. Well, when you're looking at the visits for a rural health clinic cost report, not one appointment doesn't equal one visit. One charge doesn't equal one visit. And a CPT code in 99211 is not a visit. So do not include those in here. And if you're overstating your qualifying visits on here, you're going to decrease your reimbursement and you're going to decrease your rate. So a simple patient example is if a patient came in and had a regular office visit, ENOM level, an injection, and a drug. It's one visit, 3 charges, but it's only one visit on the cost report. If another patient comes in with no ENOM level visit, but had an injection with a drug, There is no visit on the cost report, but 2 charges. So be really careful here not to overstate your visits because it can really hurt you at the end of the day. Then getting into the vaccines, and this is another area that some rural health clinics are reporting on well, and others seem to be missing on it. But keep in mind here, again, the same types of things. You need to look at your costs, your volume, making sure you have that patient detail logs that's not billed to Medicare. Look at, and this is important for flu, pneumococcal, for just Medicare alone. But for COVID-19 shots and antibodies, you can also include Medicare HMO, and Medicare will pay you for it on the cost report for also the Medicare HMO business. So make sure you're including those as well. And a lot of times with those 3 types of vaccines, flu, pneumococcal, and COVID-19, there's a lot higher volume on Medicare. So it's important to have that in there. When you're looking at bad debts, for example, this is an area that we see missing a lot of times on the cost report. It's usually blank. So keep this in mind, same requirements, same rules as every other type of bad debt, but look at that as another opportunity. Provider-based productivity for employed physicians. Again, employed providers, I'm sorry. Again, keep in mind those contracted providers should not be included in here. Right now, it's pretty easy to get that exemption through COVID to have that provider productivity exemption. But that's not an exemption that's available only through COVID. And keep in mind that that is an area that we've been successful on retro approvals, looking at the community side, the providers, and again, going back to that 0.92 versus 1.0 can make a huge difference on what Medicare is expecting you to have here for your providers. Again, all opportunities that we're looking at here are retroactive reimbursement opportunities, not just prospectively. So that's why it's important to have a documentation there. When you get into your other services, pay close attention there to services not included in your AIR and making sure you're keeping track of that. The other opportunity out there is look at consolidation of your rural health clinics as well. The rural health clinics for Medicaid, again, I don't want to get, this is very state specific, so it's different with each facility and each state, but a lot of times this is an area really to look at that's a missed opportunity out there. I'm not going to spend a lot of time on it. I know I do have a couple questions out there I need to follow up on from a few of you, but this is an area that if you have any questions as you're getting into it, let me know. But it's an area that's really not utilized as high as it should be. There's opportunities there. Looking at other opportunities with rural health clinics, again, making sure that you establish reviews to ensure your levels of service are billed appropriately to your non-governmental payers, and have a process for collections for those private commercial payers. Even if a commercial payers are a smaller percentage of your business, that could be your profit at the end of the day. Look to make sure with your Medicare HMOs, how are you being reimbursed? With Medicaid, making sure that you have everything set up that's state specific. Medicaid HMOs, again, contracts, and on the commercial side as well. And again, keep in mind that that could be your reimbursement at the end of the day as some of these other types of reimbursement outside of Medicare specifically. Sole community hospitals is the third healthcare provider type. I'll just cover it really briefly. The biggest area here is, again, is it needs, they can have a higher APC rate, and then their dish adjustment is a lot less. I'm not going to cover it in great detail, but if you are one of these, keep in mind a lot of things I've already mentioned. It's still important to do that because it'll help you on your Medicaid side. Right now, there's about 450 hospitals in 47 states, so not as large of a provider type as the critical access hospitals, or especially the rural health clinics. If you have more questions on that, let me know. The fourth area is the Medicare dependent hospitals. For the provider type there, again, you can't be a sole community hospital. There's a lot less of these hospitals across the United States as well. And again, it's the opportunity there to look at for additional volume as well. And the primary benefit here, again, is eligibility for payments based on hospital-specific payment rates. So that's the benefit here. Right now, the Medicare dependent hospital and the low volume is currently set to sunset in September, hoping that will still be extended, but there is a few that actually do receive a low volume based off their location and the limited number of discharges they have as well. So hopefully we'll see those extended, but at this time, those programs are both set to sunset in September. The fifth area is a rural referral center. Again, not a huge amount of hospitals on this as well, but this is important to look at. Again, that dish cap percentage is a lot lower in order to be eligible for the dish as well as the 340B. So those are the biggest benefits for that one as well, looking at supporting those high volume rural hospitals who treat complicated cases. Rural health reimbursement for PPS facilities. Again, the strategy that I mentioned earlier is not just for cost reimbursed or critical access hospitals and rural health clinics. Keep in mind those Medicare cost report is current for your current reimbursement. It's also used for your Medicaid and your DISH information. It helps with your rate setting implication. It still has relevance there. And again, it's important just to look at it from the monitoring of your performance. Where are your volumes? If you're losing money on Medicare, or what other opportunities you have. And again, your S10 has become more important now than it ever has. At one point in time, it was not as important as it was. So that helps you look at your indigent volume. Make sure you look at those Medicare bad debts and model any of your impacts. Looking at the Medicaid cost report, again, it's an annual requirement. Looking at those annual claims, making sure that everything's in there appropriately so your UPL is able to give you additional funding that way, your supplemental payments, optimizing your share of that, and then monitoring and reconciling your HMO clearings too, and looking at your uncompensated care and making sure that's accurate again to make sure you have that additional utilization in there. Other reimbursement opportunities, again, on those commercial contracts, make sure that you have accurate charging there and that you're getting reimbursed enough so that you are not losing money on those services and they're helping you with your profit. Looking at the grants and donations, these are excellent opportunities for cost-based reimbursed facilities because you do not have to offset them as an A8 adjustment. So anytime you're able to pick that up. Now, the caveat in that is any of the grants you receive from HRSA or HHS that were COVID related, you can't use the expenses from the cost report, and also the expenses for HHS, you'll have to discount them based off of that. But generally speaking, outside of COVID timeframe, these are excellent opportunities, again, to look at additional other reimbursement. Other reimbursement opportunities, again, that you don't want to miss out on are the health professional shortage area. Again, that's that 10% incentive for professional services. Also looking at the HPSA designation, looking at those 340B, making sure that you have all those provider-based clinics signed up for the 340B, and then also looking at your contracted pharmacy, making sure that your managed care contracts include your appropriate reimbursement model. And if you're on a border or close to another state, or if you're in a tourist area where you get individuals from other state, make sure you look at those out-of-state Medicaid patients. It's important not to miss those as opportunities as well. And then always look at your revenue cycle. There seems to always be opportunities there as well. If you're part of a health system with rural health facilities, again, keep in mind there that rural area is a little different than the urban area, and there's different funding opportunities there. It might not be significant for the urban facility, but for those rural facilities, it can make a huge difference. Look at the home office cost report, making sure all those related services go down or are being allocated down to the rural facility that does get cost-based reimbursement. If you're looking at Medicare managed care contracts, making sure that that's there and there's a different strategy for that. Even though, again, that facility is small, the coverage area may be quite large. And again, a Medicare cost report, making sure that all those appropriate costs are going down there, making sure that rural health clinic gets what it needs to. I know with systems, when they're the same fiscal year on, there's a lot of cost reports that are all due at the same time. So I'd love to say in the middle of the year when you have nothing to do, but that's not how that works either. But sometimes the end of the year isn't the best time to always look at all these scenarios, but just take a mind and take a look at that. Review the charge master again too. I've seen one system that I've seen a couple different scenarios where the charge master continued to increase or the charges were extremely high. And again, for a critical access hospital, when 20% of that business, it goes over to the patient as a copay, this facility actually had 18% cost to charge ratio and 20% goes to the patient. So they were receiving no reimbursement from Medicare because their cost to charge ratio was so low. So just keep in mind looking at those charge master rates. And that's not just for when you're part of a health system, but that was the example from there. Make sure someone on your team understands rural health and the opportunities that exist with it. There are rural hospitals are different from the urbans. And sometimes what's good for an urban facility is not necessarily the most beneficial for a rural hospital. Really quick on COVID, I know that everybody's already heard a lot about this on a lot of different other webinars as well. Biggest thing on all of this, keep your documentation, make sure you have everything available because at some point in time, someone's going to come back and ask for it. Making sure you are not double dipping, make sure that you're not overlapping, I guess I'm calling it here, don't double dip, make sure you keep your documentation. I know most rural hospitals were sitting with more cash pre-COVID than they were pre-COVID through a lot of different methods. And throughout this whole process, it's been very, very hard because that federal funding masked that instability of those at-risk rural hospitals. They really are appearing more financially stable than they really are. Education, I feel, is extremely important to make sure everybody across your facility, C-suite usually understands this a lot more. Hopefully you have your board understanding it as well. But keep it in mind when you're looking at different service lines, if you're looking at, there's two scenarios to this. Sometimes there were CEOs that we'll spend the money because we're cost-based reimbursement, Medicare will pay for it. But as we already know, that's not exactly how that works. Also, when you're looking at eliminating service lines, make sure you're actually looking at the service line that has, if you look at a service line that has higher Medicare reimbursement or higher Medicare payer mix, you're going to have to cut a lot more expenses to get there. So if you're looking at a desired outcome of, let's say, $100,000 for bottom line savings, and you're looking at the inpatient unit, you'd have to cut $333,000 of costs to gain that $100,000 bottom line savings, because generally speaking, you have a 70% Medicare. So keep in mind, you're not going to get a dollar for dollar impact in your cost-based reimbursed facilities like you are in your other types of businesses as well. I know one of the myths out there is we're a critical access hospital, for example, or a cost-based reimbursed facility. So we should always break even because we are reimbursed costs. But keep in mind, you still have to make up the difference on that Medicare shortfall in non-Medicare patients. And again, keep communication up there. And it's really important to do that. So looking at the rural healthcare in the future, so in December 2020, as part of the Consolidated Appropriations Act, they created a Rural Emergency Hospital, or REA, that's supposed to be effective January 1st, 2023. It was in response to a loss of emergency services in a lot of those rural areas due to additional hospital closures. So even though they established a critical access hospital program, which kept a lot of hospitals open, there's still a significant vulnerability in rural America. So they are coming up with this Rural Emergency Hospital designation out there as well. It's the first new rural health provider that Congress has established since 1997. So this is a pretty major big deal as far as when we're looking at that rural health strategy. But again, it's not something you just want to assume it's going to be best for you. You really want to model it. Cash is still the king, of course, it always is. If you don't have cash, it makes it pretty hard to operate. The unthinkable can happen and the bottom can drop out, and that's kind of what's happened over the last couple of years. There's hospital consolidations still on the increase. There's still 80 rural hospitals that have closed since 2010, so in the last 12 years. There's still telemedicine. We're still currently in the pandemic. It's expected to go another 4 months, but at some point in time, that's another, we got to see where that's going to end up at. And healthcare is the largest industry right now. So the U.S. healthcare spending is up 9.7% in 2020 to $4.1 trillion. That's a lot of zeros left at the decimal, with an average of $12,500 a person. And with the U.S. healthcare spending now being 19.7% of the GDP, we need the stability to stay there, but it also makes it a really hard target in the budget. So now's the time to keep as much cash as you can, try to strategize the best that you can, and look at other funding opportunities whenever you can. And there's always technology and infrastructure to look at as well. It seems like that's changed constantly. So kind of in summary really quick, again, rural is different than urban. Hopefully all this sounds very repetitive now because I've repeated it several times. But the biggest thing is just to ensure that you receive the funds entitled to you, nothing more, nothing less, but always look for other opportunities or programs that are available to help support your rural provider. Reinvest in your facilities and provider and staff to provide the best care and services to your community, and specifically your community needs. Everybody's are a little different. Don't be all things for all people, but do what you can and do it best. And again, my passion is to keep rural healthcare available to the 20% of Americans that call rural home, making sure that you look at your cost report, that it's not informational only, whether you're a cost-based reimbursed facility or not. It's still important to have the accuracy out there because it affects other programs such as Medicaid. Make sure you model all your changes. And then this is a lot of the references, and I know that slides will be handed out or sent out after this, but here's a lot of references and resources that I've gone through. But the Rural Health Information Hub out there is, again, lots of information. They have a listserv you can sign up for. They'll send you emails with opportunities and news related to rural health. I would strongly recommend you do that. The other one out there is the Med Learning, is another excellent one that has fact sheets that you can actually read and understand, which is really important because sometimes when we get into healthcare or a lot of other industries, it is really hard to understand the terminology sometimes. So I know that we're pushing right at noon right now, so or at the end of our hour, I should say, noon Eastern. So I apologize, we're running right out of time, but please still free to answer or send questions over. My contact information will be on the end of the presentation as well. So thank you very much for all of you for spending time with me for the last hour, and hopefully everybody, either you have confirmation of what you already knew, you learned something new, or if you have any questions, please feel free to reach out. Thank you.
And that concludes our session today. Thank you everyone for joining us. As Karen mentioned, we will be sending out a recording of the presentation as well as copy of the slides within the next few days to all of you. If you have any questions in the meantime, please get with Karen and enjoy the rest of your day.